I was one of those guys that just afraid of the doctor. So I wasn't going for a regular checkup. But I had a high blood pressure condition that I wasn't aware of. Just blindsided me. I go to work in the evening, so prior to work I usually go about an hour at the gym before I go to work. Went in a little bit earlier, did cardio, worked out, and then at the end of my workout, went to play some basketball. And all of a sudden, I just felt dizzy. And I started holding on to the wall, holding on to my friends. He said, lift your left hands, and I barely could move my left hands. So he said, immediately call 911, his guy having a stroke. And I remember the paramedics coming by and they said, they ain't able to save this guy, we have to airlift him immediately to Grady Hospital. I mean, it was a blood clot to the brain. It was a major, major stroke. So they had to go through my body, up in my brain, and take out the blood clot.
The most common type of stroke is when an artery is blocked. When that artery is blocked, then blood flow can't get to the brain, and that part of the brain stops working. If that part of the brain stops working, then you have symptoms like weakness on one side of the body or difficulty speaking.
Stroke is the 5th leading cause of death for all Americans, including African Americans, but African Americans are twice as likely to have a stroke compared to whites.
Grady was really good to take good care of me. Even today, they still do. They follow up with me after the hospital and make sure everything was okay. Hardest time I had, changing my diet. I think it was the hardest time. I mean, like I said, after 40 years of eating a certain way, all of a sudden to change that. But I think it's a change for life. Prior to my stroke, I didn't eat a lot of fruits and vegetables at all. Today, 2 to 4 pieces of fruits a day and vegetables 2 to 3 times a day. My kids, they were happy when I came home, and when they see me exercising and trying to eat right, you know, they encouraged me, and I try to get them encouraged also so we can do this together.
We want people to know that stroke is preventable and treatable, and there is hope. There are things you can do. You can work with your doctor to reduce your risk, and regularly checking your blood pressure is important.
I keep a log of my blood pressure, and it's been controlled. This whole year it hasn't gone over 120. I want to be a spokesperson for this, to be honest with you. Well, I want to say, first thing is, please, please, please go to the doctor. Get yourself checked first. It's very important to get yourself checked, see where you are. And if you have to go on medication, do it. All my friends, I mean, I tell them every single day, listen, man, you got to change your diet 100%. Start with your diet first, and then just gradually start walking, start getting this exercise. So all my friends, you know, I'm an advocate of being healthy and eating right now. And I think what motivates me the most is my 4 kids. I want to be able to see them grow up, go to college, you know, have their own family. And I mean, passing down this eating right and the healthy lifestyle, and they're passing that on to their kids. So I think that's my biggest motivation, just watching my kids grow up and showing a good example.
Coverdell Registry was really about 2 things, and has been since its inception nearly 15 years ago. It's about collecting data about patients and their care, and using that data to drive the process of improvement. Understanding the components of better care, faster care, which includes faster diagnostic services, understanding that data and how to change your system, making sure treatments are provided when indicated, means that more patients have improvement and more patients have fewer recurrent strokes and complications of care. The Coverdell program has quite literally saved lives. The data that we have shows that mortality or death rates are less from stroke in the communities around hospitals that provide this type of care.
Good afternoon. Thank you for joining us for Mind Your Risks and Act Fast to Prevent and Treat Strokes, the Public Health Grand Rounds for May 2016. Let's get started. It's really an interesting show, but first, a few housekeeping slides. We have continuing education credits available for all of our Public Health Grand Round sessions. Please see our website for more information. We're also tweeting today, and we're on all of your favorite social media websites. Please use hashtag CDC Grand Rounds for all your tweeting needs. We also have a featured video segment on YouTube and our website called Beyond the Data that has some take-home messages for you to mind your risks and act fast to prevent and treat strokes. We also have partnered with the CDC Public Health Library to feature scientific articles related to strokes. You can find more at the cdc.gov/library/SciClips website. Here is a preview of our upcoming Grand Round sessions. Please join us live or on the web at your convenience. And you can find out more about your personal risks for stroke. Please go to this website and put in your risks for stroke and play around with it, because you can figure out what you can do now to prevent your risks for stroke down the road in 10 years and a lifetime. In addition to our outstanding featured speakers, I'd also like to take a moment to acknowledge the important contributions of the individuals listed here. Thank you. And now for a few words from CDC's Director, Dr. Tom Frieden.
Stroke is one of the leading killers in this country. Over the past decade, we've made real progress. The number of deaths from stroke has fallen by about 20,000 per year, a reduction of 25%. This progress is due in part to broad efforts, such as the Million Hearts Initiative, which has raised awareness at the community level and the provider level, and the National Institute of Health Mind Your Risks campaign, which encourages individuals to know and take action to reduce their risk of stroke. Another effort you'll hear about today is the Paul Coverdell National Acute Stroke Program. This program works with states and stroke centers to integrate data measurement and clinical quality improvement and lead to better outcomes. Stroke centers across the country have reduced the time between patient entry to hospital and the start of critically important medicines such as TPA. Hospitals participating in this program have reduced this time from 74 minutes to 59 minutes on average, in a time when every minute can count. This is important. Treatment started within 60 minutes reduces mortality and long-term disability. For stroke care, having clinical and public health systems work closely together isn't just a good idea. It can be a matter of life and death. With improved outcomes, it's even more important to focus on recovery and rehabilitation. This will be an increasingly important component of the stroke continuum of care. Primary prevention remains fundamental. Too many people still die from strokes that are preventable. Nearly 800,000 Americans will have a stroke this year, and only 75% of them will survive. Most of those strokes could have been prevented with simple, inexpensive interventions available today, such as controlling blood pressure. Together, we can do much more to control high blood pressure, reduce harmful cholesterol, and reduce smoking and exposure to secondhand smoke. Stroke is preventable and treatable if we understand and reduce our risks and act fast to initiate optimal care during a stroke event. Thank you.
Thanks, Phoebe. It's a pleasure to be here. And as Dr. Frieden mentioned, stroke is heavily preventable, so getting the message out can really make a huge difference. And so that's why we're happy to be here today and participate in this messaging campaign. So as Dr. Frieden mentioned, stroke is on the run. So cerebral vascular disease and stroke rates have been decreasing in the U.S. For the last 50 years, and it's about a 70% decline since the country realized the role of hypertension in heart disease and stroke. And it dropped from the third leading cause of mortality to the fifth leading cause of mortality. And we think that the decline of stroke is attributable to the control of known vascular risk factors. The point, though, is that although we've made such progress, it's a clear indication that we can prevent stroke, but we certainly haven't optimized the situation in terms of risk factors, and that's what we'll talk to you today about. So hypertension is overwhelmingly the greatest cerebral vascular disease risk factor. So it eclipses cholesterol, which is more important in heart attack, but hypertension is the primary driver in stroke. And 1/3 of the U.S. population over age 18 is known to have high blood pressure. But only half of those with high blood pressure have their blood pressure controlled. So there's the easy answer in terms of how we can make a difference, is trying to improve that 50% figure. The other thing we know now is that blood pressure control is a moving target. We have arbitrary limits that we start treatment at. And in general, the going consensus is that somewhere around 140/90, we want to keep blood pressure below that limit. But in fact, the studies that have been taken, patients have participated in most recently, the SPRINT trial, the SPS3, and the ACCORD studies, all show that stroke rates decrease even as you get your blood pressure down below 140, down towards the 120s, or even lower than the 120 systolic. So we don't actually know for an individual person what is the optimal blood pressure. The other thing that we have to mention is that although stroke rates have been decreasing, the stroke is related heavily to the disease that occurs with type 2 diabetes and obesity. And so we are worried that as these rates increase, that the stroke rates will again begin to increase again. So another kind of warning that we should be aware of. The other point to make is that there is a tragedy in the U.S. in the sense that there is a tremendous disparity in stroke incidence and mortality, with African American risks being considerably 2 to 3 times higher than Caucasians. Although the stroke rates are declining in African Americans, the slope is parallel to what you see in Caucasians, but there's still a huge difference between Caucasians and African Americans, particularly in middle-aged African Americans. We have been working with Dr. George and Virginia Howard from the University of Alabama on what we call the REGARD study. It's following 30,000 people now over at least 10 years. What they found that 40% of the increased stroke risk in blacks can be explained by known risk factors. Half of that is due to uncontrolled high blood pressure. The rest is unexplained. One potential answer is that African Americans may have a many-fold higher stroke risk for every 10 millimeter mercury elevation in blood pressure as compared to Caucasians. So in Caucasians, for every 10 millimeter increase in blood pressure, you usually see about an 8% increase in stroke risk, but it's 3 times that, 24% in African Americans. And the stroke risk in African Americans and the disparity is greatest in middle-aged African Americans. African Americans over age 65, there's much less difference, if any difference, between that and Caucasians. So the efforts on hypertension in African Americans, I think, need to be targeted at middle-aged African Americans, particularly African American males in that age range. Now, let's just talk a little bit about what stroke is so everybody's on the same page. There's 2 basic types of stroke. One is ischemic, which causes infarction, and the other one is hemorrhagic, which causes bleeding into the brain or around the brain. Ischemic infarction is most commonly due to embolism, so a clot that forms in the circulation, washes into the blood vessels going to the brain, blocks a blood vessel in the brain. There is also hypertensive small vessel disease in deep brain blood vessels, usually small blood vessels. For neurologists and physicians, they are known to cause what's called lacuna infarcts, which are tiny infarcts in the deep parts of the brain, particularly in the white matter, which are the wires that connect different brain regions or to connect the brain regions to the spinal cord. And these occur almost exclusively in people with hypertension. There is another type of stroke which is much less common called a low flow stroke, and it's usually due to narrowing in the blood vessels in the neck where there's poor blood flow above, and so the brain suffers chronically from low blood flow and progressive stroke, but that's actually quite uncommon. On the hemorrhagic side, hypertension disease is the major cause of serious hemorrhage into the brain. This is the same disease that occurs in the blood vessels that gives rise to lacunar stroke, where the blood vessels are diseased and become very narrow and scarred and then block off. But that same hypertensive process causes scarring the arteries and a break in the artery wall, which can lead to hemorrhage into the deep substance of the brain. The problem with hypertensive hemorrhages is that the brain has a gel-like makeup, and so the arteries actually inject blood with such force that they cut through the brain and cause mechanical damage to the brain, as well as damage due to the toxic blood products. Lobar hemorrhage is hemorrhage around the surface of the brain. We call the lobes of the brain: frontal lobe, temporal lobe, parietal lobe, occipital lobe. It's most commonly due to amyloid angiopathy. Amyloid is the same amyloid that you see in Alzheimer's disease. In Alzheimer's disease, it forms plaques in the interstitial spaces. In amyloid angiopathy, the amyloid forms around blood vessels. It damages the blood vessels, and they will bleed. Vascular malformations are the other major cause of hemorrhage. These can be arterial venous malformations, which are tangles of arteries and veins in the brain, aneurysms, which are defects in the wall of the artery with ballooning of the artery and then a burst. These are, as you can imagine, are quite serious and devastating conditions when they occur. If we want to make a public impact in stroke, the greatest impact is going to be with prevention on the public health. That's where we can, as Dr. Frieden mentioned, save thousands of people, tens of thousands of people from stroke. And we know what the risk factors are for vascular disease, and we basically need to really develop precision medicine to really get a patient optimized on their risk factors. In terms of early treatment, we'll hear more about this from Michael. But the point here is that, particularly in ischemic stroke, there's a lack of blood flow to the brain, and that causes the cells to die over time. That time frame is usually minutes to hours, and so necessarily to make a difference, to get the blood flow back to the brain with clot-dissolving medicine or devices that pull clots out of the brain, you have to do that in minutes, maybe a couple hours, and then after that it's too late. So this is a systems problem in getting the message out, what are the signs of stroke, and making sure that people get to the emergency room. The emergencies are ready for them. Some places now are actually sending out ambulances with CT scans to treat people at the doorstep, anything to do to cut down on the time frame of treatment, because timely treatment can really help. In hemorrhagic stroke, similarly, if you survive the hemorrhage, you have an abnormality in a blood vessel, and there's only a clot, a blood clot that's preventing you from death, that's sealed that hole in that vessel. And so getting that vessel fixed is incredibly important to survive. Recovery is another area, an exciting area in neuroscience right now, because the general rule is that when there is brain damage due to stroke, if you survive the stroke, the neurologic deficits that come on at the onset of the stroke, sudden onset of a stroke-like symptoms, they stay, but over time the brain repairs itself, and the deficits, as a rule, become less. The question is, how much better do they get? In general, they get about 70%, you get about 70% improvement over time. But for some people with a devastating stroke, 77% improvement, they're still dependent. So trying to understand how the brain rewires, how it reconnects, how the brain repairs itself is one of the hottest topics in neuroscience right now. And we're hoping to understand that so that we can bring new treatments to people that enhance the recovery after stroke. We have a number of initiatives at the NIH. We have set up a stroke network around the country to do clinical trials in stroke. These are experienced investigators who are running basically a machine to do stroke trials in either prevention, treatment, or recovery. So we're looking forward. This is kind of new. So we're looking forward to tremendous efficiencies and successes due to this organized approach to stroke across the country. The next point I want to make, and the final point, is that, in fact, most of the strokes that occur are silent, that no one even knows they've occurred. And that is because they're small and they occur in regions of the brain that don't have an associated symptom that is going to be evident at their onset. So large areas of the brain, particularly frontal lobes, deep parts of the brain, certain areas that you can have a stroke and you will not know you have it. Now, if one does autopsy of patients who, say, have dementia, when they die, we find that about half of them have a combination of Alzheimer's disease and small strokes. Most of those they were unaware of. So we think that the importance of the small strokes, which are incredibly common, affecting potentially 30% of people by the time they're age 80, are contributing to dementia. In addition, there is another condition called diffuse white matter disease, which you see here on the slide, this white area here on the brain, shown better on the next slide on MRI scan. So you can see the healthy color of the brain on the left and these, what we call diffuse white matter disease, on the right. And that's also associated with cognitive impairment with aging and with hypertension. And frequently these people also have small strokes that become confluent to cause this diffuse white matter disease. But there's something else that's going on there. We're not exactly sure how it happens, but in almost all the cases you see this arterial sclerosis, which is the hypertensive vascular disease. You see thinning of the myelin coating of the wires, the axons of the brain, and you may see dropout of actually axons themselves. So this is a disease that's affecting the deep wires of the brain, incredibly common. Begins probably in people who are hypertensive when they're in their 40s, and in people who are above 80, about 80% of people will have this. So one question in my mind is this something that we can really target to optimize therapy? It's so common, related to hypertension. It's a hypothesis. We have, at NINDS, have been running a number of what we think are really important trials at the moment and research projects. The CREST-2 trial is one that we need help with in terms of getting people to understand it and improve our enrollments. What we're trying to do in the CREST-2 trial is to understand what's the best therapy for people who have asymptomatic atherosclerosis in the carotid artery. Symptomatic stenosis in the carotid artery is a very high risk for stroke. And so any intervention, surgical or endovascular stenting, that opens that artery is definitely beneficial and needs to happen. But most people with atherosclerosis in the carotid are asymptomatic. It's not clear what is their best treatment. They certainly do not have the same risk as people who are symptomatic. And that's what this trial is trying to do. But we're not simply randomizing people to go home and take the pills your doctor gave you. We're randomizing these interventions against aggressive medical therapy, getting the risk factors under control, improving lifestyle. So does the best medical therapy actually do better than the interventions? Important. We talked about the relationship between cerebral vascular disease and dementia, and the U.S. Congress has made dementia, trying to make a dent in the dementia epidemic that's going to come to this country as our population ages, a very high priority. So funding has gone to the NIH to try and work on this. And as I mentioned, if we can make a better effort at reducing our vascular risk factors, we may be able to use what we already know to decrease the risk of dementia. And so we have a number of projects with regard to this idea. And then we're also trying to attack the disparities with intervention programs, targeted, culturally sensitive intervention programs to improve hypertension control in persons who are at highest risk, particularly in African Americans. So this just goes and shows you what I talked about before, is the relationship between the declining stroke rates, which you see here in yellow, and the declining dementia rates in Canada, which you see here in blue. In addition, the Framingham Heart Study has shown that there's been also a decrease in dementia over 3 decades in their study, And a number of other countries, particularly in Scandinavian countries, have been showing the same thing. It's not, I must admit, it's not entirely clear what is the cause of the decline in dementia rates. The two things that come up all the time are the decreasing vascular risk factors, decreasing stroke, and increasing educational level. Those are seem to be the two correlates that have come out of these studies, but no one can say exactly what it is at this point. But we think it's important for people to understand this as a risk, that not only by getting your lifestyle in a more healthy state, treating your blood pressure so it's under control, prevents stroke, prevents heart attack, and we think there's good evidence, as I mentioned before, that it will decrease your risk of developing dementia. So we have a program now called the Mind Your Risk campaign, is to educate people about the dangers of hypertension, and including what has been left out of the equation for so many years is this issue of cognitive aging and healthy cognitive aging. So we have this little video to kind of scare people a little bit, but not too much, just enough to get them to start thinking about what my blood pressure is and what we should do about it. And we have on our campaign website lots of information for folks who want to understand how they can do that. And I'm just going to end again with the point that Dr. Frieden started with, is that stroke is preventable. There's many different risk factors that we know about, that we know how to control, and we think that this could have a tremendous public impact, not only for stroke, but also for decreasing dementia risk. So with that, I'd like to introduce Cheryl Bushnell, who's a professor of neurology and director of the Comprehensive Stroke Center at Wake Forest, who's going to talk to us about stroke prevention in women. Thank you.
Thank you, Dr. Korshets. It's really a pleasure and an honor to be here to talk about my favorite topic, which is stroke prevention in women. And hopefully by the end of the next few minutes, you'll know what these unique risks are for women, and knowing the difference could potentially make the difference, hopefully. I'm going to talk about the topic initially with some statistics and just give you a sense that basically women live longer, and once you live longer, you have a higher lifetime risk of stroke. And this is shown here in data from Framingham that after age 55, women have an 18% risk of lifetime of stroke in their lifetime versus men who have a 14% risk of stroke. And what's also important is that if you look at all the people who die from stroke, women make up about 60%, so the majority. And the reason for that, again, is probably related to the fact that they live longer. And then when you look at the women who've had strokes and have survived, and you have the disability associated with the stroke, there are actually 200,000 more disabled women with stroke compared to men. The other really important issue is that study after study has shown that women have worse outcomes after a stroke. This could be related to functional status. Often it relates to mood and depression, and it relates to quality of life overall. So women do worse after stroke. This is something that still needs further study. But all the data I'm showing you right now is to convince you that the reason we want to do prevention is to avoid these bad outcomes. So prevention is really the key here. I was one of the lead authors on the Stroke Prevention in Women Guideline through the American Heart Association. And in that paper, we took all of the women-specific risk factors and took them individually and analyzed the data that we could find about each risk factor. And on this table on the left-hand column, we have the risk factors that are women-specific. So we have pregnancy itself, we have preeclampsia, eclampsia, and gestational diabetes, hormonal contraception use, postmenopausal hormone use, and changes in hormone status. So those are the women-specific issues. But now we have those that are more prevalent or stronger in women versus men, and that includes migraines with aura, atrial fibrillation, diabetes, hypertension, depression, and psychosocial stress. And then in the third column, we have the risk factors that have a similar prevalence in men and women, Both impact stroke, but we don't know if there's a differential impact in women versus men. But of course, those are the usual suspects: physical inactivity, obesity, diet, age, prior cardiovascular disease, tobacco smoking, and metabolic syndrome. And so one of the challenges with prevention and trying to develop strategies that may target women, for example, is that we have trials on prevention where women are underrepresented. So if you look at the studies of carotid intervention trials, only 31% of the participants were women. And then if you look at the antiplatelet trials with aspirin and other antiplatelets, you can see that only 39% of the participants are women. Part of that may be to the prevalence of carotid disease, which is more common in men than women, but we still need a better representation of women in trials in order to target our prevention strategies. Taking some of these women-specific risk factors one by one, I want to start with preeclampsia. And what this particular table is showing you is modified from our guideline. And it shows you that you have in the second column from the left, you have the cardiovascular outcome. The next column is the pregnancy outcome, and then the column to the right of that is the hazard ratio, the odds ratio. And you can see that for women who've had a particular pregnancy outcome, most of which is preeclampsia, that there are actually anywhere from 1 to about 5-fold increased risk of a cardiovascular outcome with this particular pregnancy outcome compared to women with normal pregnancies. And that's over a variety of years of follow-up. And so you can see that the risk of having a stroke with preeclampsia is not just at the time of delivery. It actually can occur for years afterwards. And when we average out all of these cohort studies, it's about 2 times or double the risk in a woman with preeclampsia compared to a woman with a normal pregnancy. And so based on that information, we developed a new recommendation for our guideline, and basically to really seriously consider evaluating all women either 6 months or even earlier after they've had a preeclamptic event, and then document this as a history, as a risk factor, and start the cardiovascular risk prevention process early. The idea is that you don't have to wait until a woman is 50 before you start cardiovascular prevention. So this is why we felt this was important. It also is important because women with preeclampsia are at higher risk of developing not only stroke but cardiovascular risk factors, in particular a 4-fold risk of developing hypertension. So the other women-specific risk factor I'd like to cover is hormonal contraception. And again, with multiple cohort studies and meta-analyses, if you lump it all together, you get basically double the risk of stroke in women who use oral contraceptives versus those who don't. And then if you have, and this is with the combination estrogen and progestin pill, but if you have progestin only, there's really no associated risk of stroke. If you increase the dose of estrogen, then you can increase the risk of stroke as well. But it's really important to emphasize that we're talking about in generally young women using oral contraceptives. The absolute risk of having a stroke at that age is about 10 per 100,000 person years. And with an oral contraceptive user, it would be about 20 per 100,000. So you're talking about a very, very low incidence. But if you actually increase the age by double, so if you have a 40-year-old taking oral contraceptives, you're going to have a much higher risk of stroke in that age group, and then you'll double that if she's using oral contraceptives. But the important thing to remember is it's not just age that increases the risk of stroke in women who are using oral contraceptives. It's also risk factors that are present. So high cholesterol can, in a hormone or an oral contraceptive user, could increase the risk of stroke by 11-fold compared to someone not using oral contraceptives. Similarly, obesity, almost a 5-fold increased risk of stroke. So this is really important because there is this synergistic risk that goes along with women who use oral contraceptives and also have other risk factors. Migraines with aura is also another women-specific risk factor, but it's more prevalent in women, about 3 times more common in women than men. And again, you have about a 2-fold increased risk of stroke in migraines with aura. This is also something that we think may be related to migraine frequency. So we haven't proven that decreasing the frequency of migraines can decrease the risk of stroke yet, but that's a reasonable approach to try to keep the migraines to a minimum. But again, we're talking about often this is a young, healthy population, and so the absolute risk is actually quite low. It's about 4 additional ischemic stroke cases per 10,000 women per year when migraine aura is the underlying cause of stroke. So very, very relatively rare occurrence. And again, a synergism that occurs with migraines with aura and smoking. So here about a 2.5-fold increased risk. Using oral contraceptives and having migraine with aura about the same. You put all 3 together and you have a really high risk here, 7-fold increased risk of stroke. And so if you want to make it easy to remember, for preeclampsia, migraines with aura, and oral contraceptive, just think about doubling the risk of stroke in those women. Now, other risk factors that are really important and probably less well studied are depression and psychosocial stress. And so this increases the risk of stroke by about 30%, again confirmed in the Nurses' Health Study. But if you have men and women, both with stable high depressive symptoms, the risk is similar. But in women who've had depression that's resolving or is getting adequately treated, they still had a higher risk of stroke than men. And then atrial fibrillation is more common in women than men. And again, this is a condition associated with aging. So you have more women out there who are older. And interestingly, when treated with anticoagulants to prevent stroke, women tend to have more complications such as blood clot formation or thromboembolism, bleeding with the anticoagulant use as well. So perhaps this is an age-related phenomenon, and other comorbidities are playing into this, but again, we have a real challenge on our hands with the aging population and how to manage atrial fibrillation. Now, the other thing in our guideline that we discussed as a point of future research is the novel oral anticoagulants, which the safety and efficacy of those trials is the same for men and women, what we know right now, but a lot of elderly women may have been excluded from the trials who are frail and have borderline renal function. And so this is, again, a very high-risk population. We don't yet know enough about the novel oral anticoagulants. I'm going to talk a little bit about the risk calculator that Phoebe mentioned at the very beginning. And so this is the calculator itself, and I put in some hypothetical values here. So we have a woman who's 40 years old, African American, total cholesterol of 250, an HDL of 30, and a systolic blood pressure of 150. So her 10-year cardiovascular disease risk is 6.8%, where optimal might be 0.3%. A lifetime risk is 39% versus a target of 8%. So this is a really nice way of getting a feel for how people are doing with their risk factors. But I also want to mention that this calculator does not include age less than 40. So if you try to look at it at the 10-year risk for somebody under the age of 40, you're not going to get any output. And the reason that's important is because a lot of women-specific risk factors impact young women. So preeclampsia, hormonal contraceptive use, migraines with aura, those are things that you can't add into this risk calculator as of right now. So we know that younger women have lower risks in general, but having this risk calculator and using the women-specific risk factors would actually help in designing prevention strategies. And knowing the risk could motivate these younger women to change their lifestyles earlier. We also think that in accordance with what Dr. Koroshetz was talking about, not only decreasing the risk of stroke, but improving brain health and decreasing the risk of dementia, which is also more common in women. So we have a lot of work to do. In summary, we think that women's strategies may differ from men. We know that we have different risk factors, but we need more clinical trials to inform our prevention strategies and actually change practice. Our future research should really target prevention and improve outcomes for women. And because women live longer, we're going to have an epidemic of older women coming up, and we need to focus on the quality of that extended lifespan by preventing stroke and dementia. So I would like to stop there, and I'm going to introduce our next speaker, which is Dr. Michael Frankel. He's Professor and Director of Vascular Neurology at Emory, and he's going to talk about closing the gap, quality improvement in stroke systems of care.
Thank you so much. It's my pleasure to be here. I'm deeply honored to have been asked to present at the Grand Rounds at CDC today. My topic is to go over quality improvement and stroke systems of care and talk about the gap that exists. First, the good news: major advances in the past 20 years for prevention, acute treatment, which I will highlight, rehabilitation, have been quite important in reducing the death and disability from stroke. Much of our knowledge is driven through the clinical trial methodology, as you heard Dr. Koroshetz talk about, and how important that is to drive what we know about the best treatments that can be provided. There have been consensus opinions about the ways to construct stroke centers, the remote treatment stroke center, the primary stroke center, the comprehensive stroke center. The Joint Commission, really as an organization that certifies and accredits hospitals, has stepped in, as well as the American Heart Association and American Stroke Association, to help us understand how to improve our systems, both locally, regionally, as well as nationally. The bad news is that we are not doing an effective job in translating these advances into practice as quickly as we would like to be able to. This gap exists for a lot of different reasons: lack of leadership, poor coordination of care, lack of cooperation, and inadequate resources, particularly with people and time, creates a problem with inertia. We have fragmented systems that don't allow horizontal integration of information so that we can learn from how our care is proceeding, and whether or not the treatments we provide and the systems that we change and the processes that we create are truly having an impact. And of course, all of this leads to problems with collaboration. So the two questions which I will try to address and provide examples for: number one, how do we bridge the gap that exists? And then how do we integrate these individual components? The Paul Coverdell Acute Stroke Registry is a good example of a way to bridge this gap by improving the quality of stroke care through a collective, collaborative environment of data collection and process improvement. Within the Paul Coverdell Acute Stroke Registry, a registry that was named for the late Senator Paul Coverdell, who died of a massive stroke in the year 2000, this registry has been in place since 2001, and it is designed to specifically collect data to improve processes and outcomes. And it is also used as a way to focus on various quality indicators. Those indicators are driven by evidence, and those indicators can tell us about how quickly or how much further we have to go towards creating defect-free care, which you see is defined here as a way of looking at all quality indicators that are appropriate for a particular patient and whether or not they are all met according to the guidelines. There is a program called Get With the Guidelines, which we use in Georgia for our Coverdell Stroke Registry, which is sponsored in part by the American Heart Stroke Association and the American Heart Association. The Coverdell quality indicators include the following. They're basically lumped into several categories, dealing with timeliness of treatment, which is how quickly patients get TPA that are eligible, whether or not antithrombotic therapy is initiated, prophylaxis of treatment during the hospital stay, such as DVT prophylaxis, and then consideration of anticoagulation for the long-term treatment of atrial fibrillation and prevention of secondary stroke that occurs in patients with that problem. The screening for other risk factors such as dysphagia and smoking cessation advice being provided in counseling, stroke education being given, assessment for rehabilitation, and also discharge on antithrombotic therapy and cholesterol-reducing medication, especially statin therapy. From the Georgia Coverdell Registry, I'm showing you here a series of years from 2007 to 2013 that is highlighting the use of TPA in patients who arrive within 3 hours of last known well. And this covers about 8,000 patients per year in our registry. In fact, since we started in 2001, not shown on this slide, the number would actually be about 15% of eligible patients receiving TPA. And as you can see on the far right, we're approaching 80 to 90% by 2013 and over 90% now in the current year. Earlier treatment will improve disability and lower mortality, as you've heard already today. This data from our Georgia Coverdell Registry shows the change in the median door-to-needle time in patients in our registry over the 6-year period depicted here. The red bars that you see there are the median times going from 81 minutes down to 60 minutes, which might not seem like a lot, but when you think about every 2 minutes or every minute that goes by that 2 million neurons die in the brain, it actually has a big impact on the survival of brain neurons and patients' outcome. In order to try to determine the impact of the Coverdell Registry in Georgia, we designed our registry to recruit groups of hospitals in cohorts, and that's what this slide shows. In the tan color on your left, you see the first cohort, and that cohort of hospitals started in 2001. So this is the percentage of patients who have defect-free care in each cohort. And you can see our first cohort by 2006 was already doing pretty good at 60%. Our second cohort, as you see in blue there, just starting in 2006 and ramping up over time, showing tremendous improvement over the subsequent years of participation in the registry. Likewise, you can see in red the third cohort of about 10 hospitals, and then in green the fourth cohort of another 10 hospitals. This shows that what's happening is not some result of a secular trend or things that are out there in the community and being emphasized to improve care, but really the participation in the registry itself is having a big impact on the performance of hospitals and clinicians in that process. If we take a step back and look at how we can connect these key issues, I've just been talking to you about the circle to your right there, the quality initiatives, the Coverdell Registry, as well as the Get With the Guidelines initiative with the American Heart Association, the Joint Commission and their efforts, as well as organizations like DNV. And in Georgia, we have a unique group called the Georgia Stroke Professionals Alliance, which includes over 300 people that participate in discussions and education about ways that we can collectively improve care. These quality initiatives are really driven by consensus opinion from the American Heart Association, the American Academy of Neurology, the neuroscience nurses, and many others. Those consensus opinions are driven by the clinical trials that I mentioned, such as those in the NIH StrokeNet, as well as industry trials, and then really our public health surveillance system to tell us what's happening with the disease. Are we having an impact? How much more of an impact do we need to have, as well as those important basic science discoveries that tell us what are the underpinnings of the disease we're dealing with. So how do we take the step into integrating systems of care? How do we make this work so that we're not all operating in silos? Think of the word system as really a word that means network. And so a task force was created to define a stroke system of care and published about 10 years ago in Circulation as part of the American Heart Association, American Stroke Association initiatives. It describes the current fragmentation of stroke care as well as the components of a system, and it encourages the implementation of these systems across the country. In a similar document that really focuses on the problems with medicine and how we need to improve systems, the Crossing the Quality Chasm document from the Institute of Medicine highlights the gap that exists and uses the phrase that there is not just a gap but a chasm that exists between what we know and what we do. Creating a stroke system of care focuses on the goal of developing an effective and integrated system for stroke prevention, acute treatment, and rehabilitation. The challenge is that although there are individual components of a stroke system that can be well developed, they often operate in isolation and do not have that horizontal integration that's necessary. So the first critical function of a stroke system is really to ensure its effective interaction and collaboration amongst the agencies, the services, and the people involved. This focuses on the timely identification, transport, and treatment of patients, as well as the importance of prevention and rehabilitation of patients who've had a stroke. This applies to local areas as well as regions that can develop these systems. The stroke system also has to promote and use an organized and standardized approach. That really means within each facility and within each component of the system. And performance measures need to be a focus for process improvement as well as following outcomes. There needs to be a mechanism for evaluating the effectiveness of the performance measures as well as the entire system as a whole so that it can continue to evolve and improve. Stroke systems need to be flexible in order to improve care. They have to be customized for each state, region, or locality. It should be focused on tracking and monitoring and improving care like the Coverdell Registry has been designed. It should follow clinical pathways based on evidence and consensus opinion, and there should be smooth transitions and continuum of care after hospital discharge, which is a new focus for the Coverdell Registry, to not just talk about the hospital component of the continuum of care, but also integrate the EMS component as well as the post-discharge. The quality initiatives should really evaluate the system over time, including all patient outcomes, and there should be linkages across essential key components of the stroke system. They should be linked to other systems and entities, and obstacles to care should be identified and should be minimized, and then those gaps that exist should try to be closed as best as possible. A number of challenges remain. Stroke is a common and devastating disease, and although we're having an impact, it's still a big problem. And as Dr. Bushnell alluded to, we have an aging population that's entering the stroke-prone years, and we have to be better prepared for what's coming. Stroke care in most regions of this country remains fragmented, and we need to develop better coordination amongst the key stakeholders. In our state of Georgia, we believe we've developed an effective strategy with the Coverdell Stroke Registry, and it's had a major impact on improving public health. It's an excellent example of the intersection and the integration between clinical care and community-based public health. We are currently integrating the pre-hospital and the post-hospital phases along with the existing hospital phase by engaging the key stakeholders interested in improving those care transitions and patient outcomes. We need to build and enhance stroke systems across the U.S. as really the next critical step in improving patient outcomes. And we'll need providers and policymakers at the local, state, and national levels that will help us coordinate systems that can improve patient care and public health. I'd like to thank you and also enjoy the opportunity to introduce our next speaker, which is Dr. Jennifer Holtz, who is a medical epidemiologist at the CDC, who will be talking about stroke prevention and improving outcomes across systems. Thank you.
Good afternoon. My name is Dr. Jennifer Foltz, and I will be wrapping up this section with stroke prevention activities, improving outcomes across the systems of care. First, stroke is the 5th leading cause of death in the United States and the 2nd leading cause of death in the world. Globally, 6.5 million people die from stroke every year, and the highest rates occur in China, Russia, and surrounding countries. To have impact, stroke prevention is the best medicine. This pyramid shows factors across cardiovascular health and stroke outcomes, with examples along the right. At the base are broad-reaching factors addressing disparities in socioeconomic factors and in environmental approaches. Moving up the pyramid, the most important treatable conditions include high blood pressure, heart disease, diabetes, and transient ischemic attacks. Addressing factors at all levels of the pyramid can help prevent stroke, its morbidity, and mortality. The Million Hearts Initiative focuses on a core set of these factors that put people at high risk with the aim to prevent 1 million strokes and heart attacks by 2017. For community prevention, we need to control tobacco use, reduce sodium and eliminate artificial trans fats in our food supply. For clinical prevention, we need to further aspirin use when appropriate, control blood pressure, manage cholesterol, and stop tobacco use. Additionally, we leverage improvements by harnessing the power of health information technology and recognizing clinical innovations. There we go. The emphasis is put on controlling high blood pressure because of its potential impact on reducing strokes and heart attacks. We still must achieve hypertension control in 10 million more patients in order to prevent 1 million heart attacks and strokes. You can find resources available online. As you see with the red line in this graph, nationally we have made significant progress in stroke mortality over the past 15 years. In 2001, Congress directed CDC to implement state-based registries, and the program has grown to include over 400 hospitals, as shown by the blue line. Our funding in 2015 included additional requirements across the care continuum, engaging communities, emergency medical service responders, the emergency department, inpatient, and post-discharge care providers. However, someone still has a stroke every 4 minutes, and the system is fragmented. Outcomes are worse in disparate populations, women, and those with poor access, such as in rural areas. These reasons are why the 2015 to 2020 Coverdale Grantees mission is for statewide, data-driven quality improvement across the care continuum to drive better outcomes. I'm going to break down these components of an enhanced system of care. The Coverdale program funds statewide systems or networks of care that improve care for entire populations. Grantees advance to stroke care in 9 states, affecting over 115 people with diverse ethnicities, urbanicities, and income levels across their states. Stroke prevention requires a coordinated system across the care continuum. The patient's journey through the health system could start from health messaging in the community to act fast and call 911. Through access to quality EMS services with transfer to appropriate hospital care settings, and finally, a coordinated transition and warm handoff to their home after experiencing a stroke. Stroke prevention efforts also include cross-cutting activities that enhance care by collaborating and linking to create systems of care statewide and across the care continuum. Partnerships, information linkages, and system changes that lead to sustainability are parts of this total framework for Coverdale. Pivotal to the Coverdale framework is data-driven quality improvement activities. Grantees and CDC utilize data from a variety of sources to create performance measures and reports which drive the improvements. This is useful for the participating practitioners, health organizations, and the Coverdale states to improve data quality at the source, track progress, and target interventions and program improvement. Additional cross-site findings inform practice protocols and set standards which improve care across the nation. Moreover, the lessons from Coverdale are disseminated globally. For example, at the 2016 International Stroke Conference, there were 24 Coverdale abstracts. These key products can be found online at the Coverdale website. Finally, priority areas for stroke prevention efforts span 4 domains. First, making the investment in epidemiology and surveillance provides the necessary information to deploy effective interventions, address gaps in program delivery, and monitor and evaluate progress in achieving program goals. Secondly, stroke prevention efforts include environmental approaches. Improvements in social and physical environments support making the healthier choice easier. Third, health systems interventions can improve the clinical environment to more effectively deliver quality preventive services. Fourth, stroke prevention also focuses on community clinical linkages, which help ensure that people with or at high risks of chronic diseases have access to community resources to manage their chronic conditions. To increase awareness, we have recently expanded our stroke communication portfolio by developing new videos, fact sheets, and other consumer materials. These products can be highlighted on your organization's website, incorporated into campaign activities, or modified to reach your target populations. May is Stroke Awareness Month, and the theme is stroke across all ages. Therefore, the time is now to use these materials to facilitate stroke prevention efforts. In summary, you have heard today that stroke is preventable and treatable. We can integrate efforts across systems of care. Quality improvement is helping to bridge care gaps across populations and the care continuum, thus preventing stroke, limiting morbidity, and decreasing mortality. Also, we can address risk factors. Hypertension remains a treatable cause, risk factor for stroke, and women have an increased risk and different risks for stroke to recognize and target. And finally, if you think someone is having a stroke, act fast, call 911. Thank you. And we'll move quickly to questions and answers, so if you have them remotely, please send them in, and others in the room.
Thank you. We'd like to take this opportunity to ask Dr. Frankel to share information he has on a new program that's available for emergency medical units.
Thank you. In Georgia, we are working closely with State Office of EMS. They have an online classroom. We are providing educational presentations that can be looked at remotely by the 3,000 certified medics in our state. We focused on how to recognize stroke signs and symptoms, as well as how to identify last known well. These are key areas for a medic in order to act quickly to understand whether a patient's having a stroke, as well as knowing where to take that patient with their condition. Last year, we had a series of clinical trials that were very positive for acute stroke using catheter-based techniques to open up major blockages in the large arteries in the brain, providing level 1A evidence that that approach is effective in getting rid of or minimizing the effects of the stroke so that people can have full recovery. But those treatments are not offered at every hospital, and they are offered at comprehensive stroke centers. So one of the big questions we have to address is how do we help the medic in the field with that triage decision of whether the patient's having a severe stroke or not a severe stroke. And so we've developed an app, a smartphone app, that will help them walk through FAST, which is really face, arm, and speech problems, as well as adding a couple of additional variables that are important that determine the severity of stroke. One is whether there's eye deviation, which is E, stands for E, and D is denial or denial of deficit. So if you're not aware that you're weak, that's called denial. So it's FAST ED. We're taking this paradigm, we're teaching our medics, and we've developed an app that will help them so that if they reach a certain threshold of a score, it will trigger a notification to the medic that this is a severe stroke and they should get to the nearest comprehensive center, which will be determined by their smartphone with an embedded Waze app, so they know how close they are to the nearest comprehensive center based on traffic patterns. That's the first step really in trying to integrate data collection in the pre-hospital setting that can help us with better decisions about where the patient should be taken. So there's a lot of approaches to dealing with EMS education. This is just one example.
And is this available to EMS personnel nationwide?
It's not yet available. We're still in the prototype phase. Once we get it developed and we pilot test it in Georgia, and we feel that it's able to provide the accuracy needed for those triage decisions, then we definitely want this to be available across the country. That's the goal, to make it available to everyone. But we have a few steps to go through first. We're excited that we have a company, two companies actually, providing free service to develop this app. And the goal, again, is to make this something that's easily available to medics throughout our state as well as across the country once it's been fully vetted and worked through.
We have a question from our online audiences. How should a person react before and after a coworker is having a stroke? I'm not totally clear whether they're referring when a person returns back to work or if in the identification stage. So maybe somebody could respond to both ends of that.
I'd be happy to. It sounds like an acute stroke question. That seems to be my area for this Grand Rounds. But we have some very capable acute stroke experts here. So I would say if the question is really focused on what happens when someone has an acute stroke. You have a slide on the screen that talks about FAST. It's a wonderful acronym developed by the folks at University of Cincinnati, and it's taken off. It's easy to understand. If there's facial weakness, usually on one side, if there's arm weakness on one side, difficulty speaking, then it's important to realize that time is of the essence, that every minute that goes by, we're losing neurons, and so contacting 911, getting that person to medical attention immediately. That's really the most direct message. And working in the emergency room, I'm sure that the other physicians here can tell you that we've seen many patients whose wives or husbands have come in and said, I learned about FAST, I read it in a magazine, I heard it on TV, or I saw it somewhere, and I because I saw that, that's the reason I was able to know the symptoms of stroke and why it's a medical emergency. The mistake, because stroke is a painless condition generally, most strokes don't cause pain in terms of arm pain or leg pain, but the arm or leg is not moving, or they have difficulty speaking, they may want to sleep it off or wait, and we can't promote that. We want to make sure people know that if they have symptoms like that, they need to act quickly and call 911.
Thank you. And I'd like to thank our speakers. Thank you very much. And thank you for joining us, and we'll see you next month for Grand Rounds.